It's a pleasure for me to give you some information regarding my oral communication at the last EHA 2022 meeting regarding the pre-planned subgroup analysis of patients included in ZUMA-7 with 65 years of age or older. So as you know, ZUMA-7 is a phase 3 randomized prospective clinical trial that compares head-to-head Axicabtagene ciloleucel with the standard of care in patients with primary refractory or early relapse diffuse large B-cell lymphoma. If we talk a little bit about the design of the trial, patients with inclusion criteria were randomized 1-to-1 to receive either Axicel or the standard of care with salvage conventional chemotherapy and consolidation with autologous stem cell transplant. Of note, no bridging therapy was allowed in those patients that were randomized into the Axicel treatment arm, and also no crossover for those patients that failed the standard of care arm to be treated with Axicabtagene. Our third-line treatment was also not allowed. The primary endpoint was event-free survival. The trial was positive for the intention to treat population of patients, and the event-free survival was significantly better for those patients that were randomized to receive Axicel. So there was a pre-planned subgroup analysis that was looking at the elderly population of patients. That was basically the objective of the oral presentation. And we were looking in this group of 109 patients to the clinical characteristics of patients included in both arms, to the efficacy, to the safety and toxicity profile, and also to patient-reported outcomes. So 109 patients constitute the population to be investigated in this specific analysis. Around half of them were randomized into the Axicel arm. The others were treated with the standard of care. The first important thing I want to mention is that while more than 90% of the patients that were randomized into the Axi arm actually received the CAR-T, only 36% of the patients that were randomized into the standard of care arm were consolidated with an autologous stem cell transplant. And the main reason for not receiving consolidation with autologous stem cell transplantation was not achieving a complete remission or a partial remission with the salvage conventional chemotherapy protocols. The experimental arm, so those patients that were treated with Axi, was somewhat enriched with patients with high-risk features, so more patients with age-adjusted IPI, more patients with double hit or triple hit lymphoma, and more patients with high LDH. In spite of that, the primary endpoint, which was event-free survival, was also significantly superior for patients that were treated with Axi in front of patients being treated with the standard of care. In the same way, overall response rate and complete remission rate were also higher for the Axicel treated group in comparison to the standard of care group. And the pre-planned interim analysis regarding overall survival also benefited the group of patients that were treated with Axi, although we have to recognize that these data are still not matured for overall survival. I want to remember everybody that the median follow-up of the patient was 24 months. And we also have to take into consideration that more than 50% of the patients included in the standard of care arm were treated with cellular therapy strategies upon relapse. If we look at the safety and toxicity profile, so the safety profile was quite similar to what we can expect with Axicel in patients with relapse or refractory diffuse large B-cell lymphoma. Maybe the incidence of grade 3 or plus CRS and neurological events was slightly higher in this elderly population of patients, but overall the treatment was well tolerated and there were no new safety or toxicity events. And finally, if we look at the patient-reported outcomes, we have to say that for those patients that were treated with CAR-T, all the outcomes looked at day 100 and 150. They were favoring this group of patients being treated with Axi than those patients being treated with the standard of care, indicating that with the experimental arm going back to normal life was significantly quicker. So basically the lessons that we can learn from this subgroup analysis is that Axicel represents really an effective treatment with a good toxicity profile in this elderly population of patients with primary refractory or early relapse diffuse large B-cell lymphoma that do not have in reality curative treatment strategies. So the introduction of CAR-T in this specific population of patients represents a significant change in the treatment landscape of these patients. So in the intention to treat population of patients, Axicabtagene has already been approved by the FDA and has already appeared in the last version of the NCCN guidelines as a potential treatment strategy, second line for those patients that are eligible for CAR-T with or without bridging therapy. Most probably the EMA is going to approve Axicabtagene as second-line treatment strategy also for primary refractory and for early relapse patients with diffuse large B-cell lymphoma. In this sense, I think that probably in the near future and outside prospective clinical trials, we will be seeing this treatment being used in the elderly population of patients. I have already mentioned before that these patients, when they are primary refractory or they have an early relapse, there are no curative treatment strategies for them. So the possibility to use Axicabtagene is going to represent a significant change, probably in the long-term outcome of these patients, and of course in the potential of giving a curative treatment strategy for them.